Hello, my name is Rebecca Ivers. I'm Professor of Public Health and Head of the School of Population Health at the University of New South Wales in Sydney, Australia. And I'm delighted to come to you here from the land of the Gadigal and Wangal people, Indigenous peoples of Australia, and I pay my respect to Elders past, present and future, and to any First Nations people here with us today or listening to this talk. I'm going to be talking to you today about falls in children, and partly I'm talking to you because I was one of the executive editors of the recently launched Step Safely technical package, which was a program of work we put together for the World Health Organization on strategies for preventing and managing falls across the life course earlier this year. I'm going to be talking through some strategies about the burden of falls in children globally and how to prevent them. So what do we know about the global burden of falls? In 2019, falls were responsible for 31,000 deaths among children and adolescents aged under 15 around the world. Like all other injuries, boys are overrepresented in falls and they're more likely to die from falls than girls. Around 66% of fatal falls among children were from a height, 8% from falls on the same level. And there's a lot of falls about which we don't have a whole lot of information about the cause. But about 50% of the total number of disability-adjusted life years lost due to falls occur in children less than 15 years old. And so it is a significant burden. There is a bit of inequity around falls around the world. Child fall mortality rates are up to 3 times higher in the low and middle income countries in the world than in high income countries setting. And again, like all other injuries, that's the case. The highest fatal child fall rates are in the low and middle income countries of Southeast Asia and the Eastern Mediterranean. And that may well be because more children are falling out of buildings, maybe because more children are in the workforce and are falling in those workplaces. This is showing you some visualizations from the Global Burden of Diseases studies, and it just shows you where falls sit in the global burden. And you can see in the top graphic, that's the mortality from high STI countries, both for males and females aged 5 to 14 years in 2019. And on the lower one, it's for the low STI countries, so the poorest countries around the world. And you can see that for those countries, the burden of falls is smaller than in the high income countries, and there are many more other diseases that children die of, including the infectious diseases and the early neonatal diseases. So you can just gives you a bit of a snapshot of where falls sits in global mortality. Of course, falls can have really long-term impact, like all other injuries, but particularly in children, falls can be really devastating if they cause long-term disability, traumatic brain injury, and injuries and disabilities that last a lifetime. And that's why injuries in children can be devastating, because they can cause lifelong disability, causing obviously income loss for the person over the course of their life, also dependence on caretakers and very high healthcare costs across the life course. So we want to look at best ways to prevent them. Why do childhood falls? Well, it's about natural development, the evolving developmental stages. Of course, children are naturally curious about their surroundings, and those increasing levels of independence also coincide with more risk-taking behaviours. And we can see, not just for falls, but all types of injury, as children become more independent, as they learn to crawl and they learn to walk, that we see a range of different injuries over time as that development increases. But the circumstances around childhood falls are complex. It's not straightforward. So often we have risks around supervision, whether parents are appropriately supervising their children, but they interact with poverty, with issues to do with sole parenthood and hazardous environments. So when we think about preventing falls, we always need to consider the context in which they occur. And often there isn't just going to be a simple intervention about preventing falls. We have to look at parenting, we have to look at income, we have to look at parenting programs, and think of ways in which we can actually create a safe environment for that child to live in. It's not just a matter of giving parents education or stair gates and saying, off you go, that'll help prevent falls. It's more complex than that. So let's have a look at some of the child development characteristics that are related to risk of falls. For children, for very small children, 0 to 1, the development characteristics as children and babies at that age, they learn to roll over, they attempt to sit up, and then crawling, pulling to stand. And for those of you who are parents or who work with children, you'll know that these things can happen very quickly. 1 minute you can lie the child on the middle of a bed and it won't move. The next day the baby will roll over and fall off. 1 minute you put the baby on a change table, it will stay there quietly. The next minute it will learn to roll and fall off the change table and have a traumatic brain injury. So you can see the risks of falls there in that first age. They roll off furniture, they fall out of child seats, fall down stairs, into baths and onto sharp edges. And that's where supervision and appropriately mechanical interventions like baby gates are going to be helpful. As children get older, so 1 to 3 years, you can see the mobility increases. And again, the curiosity exceeds the ability to assess risk. Babies start climbing furniture and they're likely to trip over, attempt dangerous activities and fall off furniture, start falling off bunk beds. And tables and chairs and things like that as they get more independent. And then, of course, as they get older, 3 to 5 years, highly active running, jumping, climbing, they're more adventurous, they're imitating the adults and the other siblings around them, and they're more likely to experience falls outside the home. So playground equipment, falls on the sporting fields, and so on. So it makes sense. It's a logical progression with the development characteristics of the child, that increase and the risk of falls changes over the life course. But the main thing is to be aware of all of those risks and to think about appropriate prevention at the time. So where do children fall? In and around the home, in schools and playgrounds, during sports, leisure and outdoor activities, and in the workplace. So they do fall, and we can't forget that children do fall in the workplace. Children are in the workplace. They might not be in the workplace in Canada, but they will be in the workplace in other settings, and we do need to consider that. Now, I'm just going to show you again some slides. These data are quite old, but it's actually difficult to find detailed information about child injury and child falls because it's not something that we necessarily will get good, detailed, disaggregated data. These data were from the Australian Institute of Health and Welfare, and it was for a report in New South Wales, so in Australia, in 2009 to 10, so 10 or 11 years ago. But it does nicely show you the trends over time, and you can see differences in fall rates over age. Now, what this also showed us is the most common type of fall. So for children less than 1 year, what we found that the most common type of fall was falling while being carried. And again, you can imagine a parents carrying babies around, a child that's upset, you take them out of their little snuggly wrap that you might have them in, or their baby born, and you carry them, you trip, you fall over. Falls involving a bed, so children rolling off beds. For 1 to 4 years, falls involving playground equipment, followed by falls involving chairs. 5 to 8 years, falls involving playground equipment, falls on the same level from slipping, tripping and stumbling. And then from 9 to 14 years, the most common type of falls were falls involving pedestrian conveyances, followed by falls on the other level. And then, the next one, 15 to 17, other fall on the same level due to collision with or pushing by another person. That could be sporting related injuries, for example. And it just gives you a bit of sense from our real data about what happens over the age course, over the life course as children get older. So what's a pedestrian conveyance, I hear you say? Well, for all children, the 3 most common sporting activities associated with a fall-related injury were football, skateboarding and scooter riding. So when we talk about pedestrian conveyancing, they are skateboarding and scooter riding. And of course, when you talk about sport, in fact, in Australia, and I'm think it's probably similar in Canada, that actually the type of sporting injury that causes most childhood injuries is in fact football. And in Australia, that is the case for both men and for women. So football is right up there, but of course these other types of falls are also important. So when we look at falls, we also find that there are really big inequalities in injury by socioeconomic status. And like all other injuries, there is a strong socioeconomic gradient for injury in all income settings, both in rich countries and poor countries. More wealthy people are less likely to have serious injuries compared to poor people. Falls are slightly different. For sporting injuries, we do see a shift, and we can see that sporting injuries are in fact representative for in high-income countries and in high-income country populations within high-income countries. This socioeconomic gradient, though, is generally observed across all settings, home, work and transport. And as I said earlier, the child fall mortality rates are up to 3 times higher in lower middle income countries than in high income countries. For First Nations children or Indigenous children, American Indian children, the age-specific injury death rates for Indigenous children are 3 times that of non-Indigenous children. So we certainly see differences there as well. So let's just think about what are these, and I guess socioeconomic risk factors for falls. And this is important to consider. For socioeconomic status, these are risk factors for falls. If there's overcrowding, children are living in hazardous environments, and increasing technology use, which means that parents may be distracted, or the child might be distracted, more likely to fall. We also see that in urban areas, children have reduced access to green, recreational and safe open spaces, and of course live in more high-rise apartments. And then we have risk from high-rise windows and balconies. Rural areas, high risk for most falls compared to urban. And in lower middle income countries, we see more informal and poor quality housing, where we're going to see increased risks for falls, children playing unsupervised in unsafe outdoor spaces where you might have, glass or other rubbish, and children, of course, working in poor conditions where you might have risks of falls, particularly in the building industry, in mines, in quarries, and there can be a very high rate of falls in children in those settings. So let's just have a think about why socioeconomic status does impact on injury. What is it about it that makes injury rates higher? Well, we have differential exposure. There's greater exposure of disadvantaged individuals or those living in deprived areas to a wide range of hazards, dangers in work, home and commuting environments. You have differential vulnerability. People of high socioeconomic status have a broader range of resources to protect their health and safety. They've got more money, knowledge, prestige, power, and beneficial social connections. So they're better able to protect themselves. If you're riding a bike, you'll have a better quality bike that might be better maintained. You're more likely to have good quality protective equipment. You're more likely to be riding your bike on high quality roads with better policing. And then, of course, there's differential consequences by socioeconomic status following an injury. So if you have a fall injury and you're living in a rural area, you're less able to get high quality trauma care quickly. You might have less access to healthcare if you're poor, and less access to safer products and treatments. So again, differential consequences following an injury. You're less likely to recover quickly. You're less likely to get good rehabilitation. So what are the good prevention measures, and for which do we have good evidence? Well, there's a range from school-based physical skills training for children, educational programs, playground-based interventions, and so on. I'm going to go through some of these shortly. First, one of the things that we need to think about is how we use the Haddon Matrix. Now, William Haddon was an epidemiologist who really was the grandfather of injury epidemiology, and he came up with a whole lot of very useful tips for prevention. But one of the things that we use to actually, when we gauge the best way to prevent injury, is to use the Haddon Matrix. Haddon divided up the injury into 3 phases: the pre-event, so what you could do before the injury to prevent the injury; what could happen during the event to mitigate the effect of the injury, and then post-event, what were the things that could happen post-injury to actually improve outcomes. And then we look at across the child, the agent, the force of the injury, the environmental factors, and then also the socioeconomic factors. So when we apply this to the risk factors for childhood falls, you can look at each of those matrix. So in the pre-event, what are the things, the factors relate to the child that might prevent the injury? Well, the age and gender, so younger age, more likely to have an injury of a certain type, gender, male gender, increased risk of falls. Inadequate participation in physical activity. So you can see here the way in which you might use this matrix to actually target the factors which might help prevent injury before, during, and after the event. So you can see lots of different options here. Of course, injury, we need to consider context. We need to include, as I said, income, education, employment, and we need to understand the context of the effect of all of these, including poverty, on injury. So there are a wide range of risk factors, both structural and individual, that contribute to the risk of injury. And there's complex interactions between all of these factors, between environmental, organisational and personal factors, which determine health and therefore injury. What we find most effective are approaches that address systemic issues across the disease groups and strengthen the health systems. And this might include prevention programs. These might be more likely to achieve success, especially in remote or resource-poor settings where both preventive programs and health services are limited. So trying to keep a focus on systems-level programs that address more than one risk factor are going to be most effective. You're going to get best bang for buck. And of course, we always want to consider who is going to be most at risk and who needs interventions more than anyone else. In 1998, Carol Runyon published a sort of three-dimensional version of the Haddon Matrix, which I also find helpful. So we have, again, the three phases: pre-event, event, and post-event, the various factors, so the host, the agent, the physical environment and the social environment, but it also encourages to think about a whole lot of other decision criteria down here along the right-hand side. So effectiveness of the intervention, cost, is it cost effective? Freedom, equity, how does it affect stigmatisation? How does it affect community preferences? Is it feasible? And other identified criteria. So it just reminds us that it's not just a straightforward matrix that we're working with. We must consider all these other factors when we design injury prevention interventions and think about the cost, the effectiveness, who they're working for. Is it delivered in the right way? Is it, what's the preference of the community? Is it feasible? There's no point in us designing interventions in a very theoretical framework. We need to make sure that they're actually going to work in the real world. So let's have a look now at some interventions around prevention of falls. And again, for children, knowing the context of falls, we need to look at prevention in the home, in schools and playgrounds, and during sports and leisure activities, because these are the main places in which falls occur and for which we have the largest body of evidence. And these are largely brought in from Step Safely manual, which, as I said, is this technical package that the World Health Organization has just published. So thinking about in the home, and you can see here that we've got a range of different interventions, recommended, promising, and other ones which should be considered. So, for example, giving parents information about child fall risks and supporting them to reduce these risks around the home is recommended, and providing parenting programs for low-income and other marginalised families. Now, of course, giving parents information about falls and educating them is important, but we also need to make sure that this parent education is most effective when the safety advice is tailored to the family rather than generic. It relates to the distinct stages of the family, of the child's physical and cognitive development, and it's provided in a systematic manner. And it's normally most effective when it's delivered one-on-one and in conjunction with home visits and assessments by trained staff, and parents are provided safety equipment to use with it. Now, that is quite expensive, but it is also the most effective way to provide these kind of programs. The other thing to think about is parenting programs, as we see here. Now, Parenting programs, generic parenting programs that don't specifically target child injury do in fact result in reduced child injury in vulnerable families. And by that, I mean single parents, young parents, and parents with learning difficulties. There's some evidence that these kind of programs can improve the safety of home environments, and they can also help parents develop realistic expectations of their child's developmental abilities and behaviours, and can address those broader social determinants of injury, including social support, mental health, positive parenting programs, mental health, and facilitate access to supportive programs for families who need it most. So again, when you're looking at injury prevention programs, we must always go beyond the mainstream and think about who are the families, who've got the highest rates of injury, who are they, what are their risk factors, and how do we best address these in the most effective way and the most culturally safe way, making sure that the programs are tailored to those families. Giving mainstream families developed for certain communities may not be appropriate for First Nations family or for migrant families or for very low income families. You need to co-produce programs with those community groups, make sure that they're tailored to the community priorities, delivered in a way that they find acceptable, and through those community groups. So it's really important to do that, because otherwise wasting time and money just delivering generic programs that won't be effective. Now, home visits and safety assessments with multiple components can also be effective, particularly when they're accompanied by a safety product giveaway like stair gates, window guards or locks, furniture corner cushions, and advice on their installation. And of course, a little bit of evidence that having multiple home visits are more effective than single visits in changing parental behaviour, not surprisingly. Now, again, they are labour intensive, and they're not really appropriate for population-wide interventions, but they're good. Again, if you're targeting low-income families, that's appropriate, as they're at greater risk of fall-related injury, and there's evidence that home visits are effective for vulnerable households. There is also evidence that the provision of free or low-cost general home safety improvements like installation of handrails for stairs and steps, non-slip surfacing and fixing of loose carpets reduces falls among children, but also amongst older people living in those families. Some of the kind of promising interventions are things like giving families corner protectors for sharp furniture corners as part of a home safety program, improved safety measures for children's equipment and furniture, safety standards, having child-friendly housing design and building codes. And again, that's critically important when you think about children falling out of apartment buildings. And I know that's a big problem in Canada as it is in Australia. If you don't have the right building codes and you have small children falling out of high-rise windows, raising awareness of the importance of supervising young children among parents or carers, rental housing policies that ensure regular safety checks, and of course, providing opportunities for children to be active in play and recreation. Now, that's particularly important because what we do know is that having children being very active across the life course is really important. Now, one of the other things that we do want to mention is about the discouragement of baby walkers. Home visit staff should advise parents and carers who have baby walkers to discard them, especially in homes with stairs. So they can cause injuries, but they can also cause underdevelopment of the lower limbs. And parental education reduces baby walker possession, but you actually looking at voluntary standards or legislation banning walkers may reduce the risk more than parental education. So again, when we look at policy level interventions, which are likely to be the most effective, actually ones that discourage or ban baby walkers are really important. So there's some interventions for home safety. Now, these are some lovely resources here around baby walkers, and these from Parachute, just again to highlight the risk. And if you haven't looked at the Parachute website, I strongly encourage you to go and have a look. There's some beautiful resources there. One of the other things is building code changes. As I said, there's a high risk of injury and severe traumatic brain injuries and other physical injuries from children falling out of second-story windows. And this is just an example from Calgary, where the Alberta Children's Hospital was working with the City of Calgary to try and address a number of safety issues with second-story windows. So they looked at developing, they were working with the National Research Council to update building codes to ensure protection of children from window falls. So again, window falls, 15% of major trauma patients at the Children's Hospital were children who'd fallen out of windows in their own home. And I know actually even as recently as this year, colleagues have been doing some work on this in Vancouver, because again, in the trauma hospitals, they're seeing high rates of children falling out of windows. So regulations around that are likely to be very effective in reducing those kind of falls. Now, some of the other interventions, areas where we need to concentrate are in schools and playgrounds, because a high proportion of falls will fall in those settings. So some of the things that can be effective there, providing soft fall surfacing and playgrounds and playing fields, and padded or flexible goalposts, and there's lots of evidence around that. There's safety standards about the appropriate depth of soft fall surfacing, and there's some evidence about granite sand resulting in fewer fractures than wood chips, but of course they require maintenance to have soft fall, so there is some cost involved. There's some evidence around school and martial arts-based fall techniques and exercises can be effective, so bringing those into school-based teaching, into physical activity programs. There are, again, evidence around policies and playground standards for soft play surfaces and restricted fall heights. So again, policies and playground standards are really important. So again, important to lobby for those things at a national level. Again, promotion of safer trampoline use and design. So trampoline design is important. And as well, physical activity education at school and ample opportunities for active play. Again, we know that to reduce falls in older people, actually having physical activity across the life course is really important. So when we look at schools and activities, there's relatively limited information about the frequency of sports-related injury because of limitations in hospital coding of ICD-coded data sets in identifying sport injuries, but it does look like around a third of all sport and leisure injuries are linked to falls, and most are the result of either falling from a height, so off a horse, a fall during a speed or change of direction. So if you're skiing or skateboarding, you suddenly change direction, or a fall following contact or collision with someone else, like for example in soccer or football. So we know that actually for evidence in terms of prevention, relatively weak. We know things like policies requiring protective equipment, such as helmets, can be effective, and some other, promising and other kind of interventions to consider are things like awareness and access to appropriate safety equipment, like helmets, mouth guards, and other protective equipment. Enlisting respected sports personalities of others as safety role models for children, matching children to those of similar size, weight and ability in games, sports and other outdoor activities, training to coaches and others working with children in sports clubs and the parents and volunteers who support them, and education and awareness campaigns around that. Now, some of the other campaigns, and there's a lot of work that's been done around this about the need to remove children from play following concussion or other injuries. That's important. And again, there's some very, a lot of the football codes are now developing both for elite and community support concussion guidelines, but a lot of education still needs to be done around that to make sure that everyone understands the important need to remove children from play following concussion. And of course, a huge need to regularly maintain and inspect equipment and playing surfaces for wear, tear and slip and trip hazards. So that's important. So there's lots of guidelines down there around safety in the sporting environment. And it's certainly going to be something that stays high on the agenda because of the engagement of children in the important need for children to stay engaged in physical activity. So one of the other kind of interventions, this is a nice case study, is the European Child Safety Alliance has used this scorecard approach, which is monitoring progress of child safety across European countries, including fall prevention. And it's a nice way of looking at it. And you could look at this from a a provincial level or a national level to actually look at what do you actually have. National laws banning marketing of sale of baby walkers, for example. National laws requiring environmental changes to prevent children from falling out of windows, so window guard locks, and so on. So it's worthwhile thinking about trying to develop these kind of scorecards and thinking how your country or your province or your city actually rates across these. Again, remembering that injury is multisectoral, and to prevent injury, we like, education alone is never effective. You need to have changes to the environment, you need policies and systems level, and education and social marketing to back and enforcement to back that up. So always worth remembering that, always raising things up to a national level and looking at systems, policy, interventions before you start looking at modifying individual behaviour, because you're going to get most effect at that policy level. Now, we must always remember the social determinants of health, though. And again, just a reminder that when you're thinking about injury prevention, always think about who is most at risk. Where are you going to get best bang for buck in terms of intervention? Injury prevention rarely has a simple solution. The social determinants of health, the situations in which people live, work and play are also always going to have a big impact. And it's really important, as I said, to not focus on individual behaviour change alone. Always look for the systems, the policy focus. Interventions need to be co-developed with and meaningful to participants. And so, and that's really important, particularly when you're working with marginalised or underserved populations. Cultural safety is essential. You need to make sure that the program is developed with and for the community that you're targeting. You can't just focus on the mainstream approach because it will not work for different other communities. So if we think about First Nations population, we know that at a population level, we have many successful prevention programs that have been implemented to tackle many of the leading mechanisms of child injury. We know that they're not necessarily well suited to Aboriginal or First Nation communities. They might be too limiting and too rigid and not sufficiently take into consideration the local conditions, culture and social structures, or be suitable for local service providers with limited resources. And this applies all across Canada to First Nations communities. So our injury prevention strategies need to account for those factors and address the underlying social determinants of health causing these inequalities. We know that inequalities in health arise from inequalities in society. And in Canada, like in Australia, past policies of colonisation and dispossession have led to a cycle of disadvantage, poor education, high unemployment, low income, separation of families and overcrowded living conditions for some First Nation communities. So contributing to those social and health inequalities that we see in First Nations communities, which of course then leads to higher injury burden. So when you're developing prevention programs, it's critical that you need to take these into account and you design programs with communities, co-produced, co-designed, and that means actual real authentic engagement. It doesn't mean you develop a program and you adapt it for that setting. It means you work with the community to understand their priorities, co-design the program and implement in that community with that community leading, building capacity and building in sustainability. And I can't overemphasize how important that is. And that also applies to other communities, other marginalised communities. And it's really important to remember that, because if you really want to address injury, we need to work with the communities for where we're going to get greatest impact and where there is greatest need. So thank you very much for listening. If you'd like to read the Step Safely manual, you can look at it on the WHO website. The link is here. Strongly encourage you to look at the resources at Parachute in Canada, KidSafe in Australia, ROSPA in the UK, and there is a wide variety of resources available for child injury prevention. Thank you very much for your time and good luck with your prevention efforts.